Hi, Jason.
There we go.
How you doing?
I'm well.
Good.
How are you?
I'm not too sure.
Okay.
I've been, I've been having trouble with my insulin levels, glucose
Yeah.
levels. So I'm on insulin anyway, but the dose has been going up, and I've not been able to sort of get it under control. And I went back to Canada, got some more drugs, and come back. So I normally average around about 7. It's about just on the upper end of normal. Um, so I thought, shit. Anyway, it's got me on a new drug. I'm going to start this after Christmas because it makes me nauseous. I don't want to be Christmas screwed up.
Yeah.
Anyway, I bought a virtual reality headset, one of the Meta things.
Hmm.
There's a game on it that really makes you work out. Like it throws targets at you, even cut them with a sword and you punch them. And I've
Yep.
been an hour and 45 minutes on this thing over the course of the day. I took my blood sugar yesterday and I'm in normal doses of stuff. And it was down to 4.1. This morning it's at 3.1. I reduced the dose. I've cured diabetes. I should be good for a Nobel Prize in medicine.
I I've been treating a patient that gave himself a degenerative labral tear because he's doing something like a VR, like sword fighting.
Yeah,
And I'm
yeah.
like, all right, that's a new one.
Yeah, you have to be a bit careful with it, especially the boxing games. Like if you just throw punches like an idiot, you're
Yeah.
going to get yourself hurt,
Yeah.
but
That's
they really
basically
work you out. You can do an hour and a half of them without getting exhausted, so you keep on going. But
yep.
you really work up a sweat and your heart rate goes way up
Yep.
when you do this stuff. I'm
They did a
impressed. Actually.
they did a small study on like diabetics because I my dad's been a diabetic since he was 43.
Mm.
And well, he eats like trash and sits, he's an accountant. So they did this study where they took a cohort of people and they dropped them down to about 500 calories a day
Oh yeah,
for like 6 months or something like that. And the average weight loss was like 30 pounds. And then once resuming a normal diet, I think about 75% no longer had to take their blood sugar medications.
yeah. There,
Because
there was another one done where they actually dropped them to 100 calories a day max for a
wow.
week, for a week, and that
Yeah.
cleared it as well. But you got to figure, like, what the hell's the point?
Yeah.
Like, so
Yeah.
you got to enjoy your life for God's sake. And
Yeah.
so I'm a bit of a quandary now because if I keep on exercising like this, I can drop my medication way down, or I
Yep.
can keep my medication where it is and completely indulge whatever it is I want to do.
Yeah. Yeah.
I'm sure there's a happy medium in there somewhere, but I'm not sure I'm going to look for it.
Let me message Anthony. He should be available
Right.
unless one of his patients was late. Yeah, he should be along. 1 second. My father-in-law played in a seniors World Series of poker tournament in one
Oh
of
yeah.
the and his twin brother came in 27th and won $800. And then my father-in-law won the whole fucking thing. $28,000 and
Yeah.
a ring. And he's been invited to play the Tournament of Champions in Las Vegas. So he was supposed to show up because he's usually home by 2 because he gets knocked. It's 620 something people.
Mm.
So he ended up getting he just kept playing. He kept going crazy and won the whole freaking thing. He's like, hey, I'm sending because my wife works with him on a couple days a week. She's like, I'm sending you home, Nicole home with $500 for her. I'm like, great, I'll take it.
Oh
I'll
dear,
take it.
that's pretty neat.
Yeah. Yeah, he's a financial planner. I think he manages about $550 million. Like
Yeah.
he's really good. And he loves studying poker. Like he just sits there, he watches it, he reads it. all of that stuff. So
Yeah.
he was super psyched to have that. It's a once in a lifetime thing, you know?
Yeah, you need to be a nerd.
Yeah.
I had
Hey, how's it going? Sorry, I'm late.
Good, thank you.
Ah, been better.
Yeah, we've all been there.
Yeah.
There's more and more better days as you get older than there are good days. Listen, I've got something to tell you both. I'm not going to come to Chicago. I managed to fob off my trip. So you got some alternatives here. I'm not worried about your techniques.
Yep.
So what I can do is we can do it. I can do the exam online, basically. It's all there, we've been doing it. Or you can switch examiners and go down to St. Louis. So you've got the choice, and you've got that choice all the way through, because basically, I'll give you another run at it, like a number of times, and then if it's really not working out, then I suggest we change examiners, because it may be me.
Okay.
All right. So it leaves more options for us, and I'm not worried about your techniques. Okay.
Yep.
So
Yeah, Anthony and I'll talk about it depending on kind of like looking at schedules, especially traveling with like the kids, it gets a little tough.
yeah, well, you don't have to both go at the same time anyway. So
Okay.
All right. Now, what I thought I'd do today, that was what was interesting to me on the last session we had, Jason, was that one about the paresthesia in the hand.
Yep.
So I thought I'd cover that in more detail.
Yep.
Okay. Did you see the recording, Hanley?
I didn't catch that one, no. I'll take a look at it though today.
I think Jason would rather you didn't.
Okay.
No, as I reflected on it, I mean, like I went so I mean, it was one of those kind of like weird brain farts where you're like looking at it and being like, why did I start going north? I should have stayed south. I should have been looking at the sensation. You're right. I should have been looking at the hand weakness for the intrinsics. I automatically went to someplace more familiar than I did someplace a little more unfamiliar. But again, like we talked about the inner ear and the tympani muscle,
Yeah.
again, the normal, it doesn't matter really where it is. It's, you know, even if it's an unfamiliar body part,
It's the same process.
the same principles still apply. And I
Yeah.
fell into that same trap that I recognized from beforehand. And that, yeah. So looking back on it, I should have gone into sensation. I should have been looking for borders, and I should have been looking for weakness in the hand. And I probably would have gotten a much better answer than what I did and stopped getting off track. And
Well,
if I
if
didn't find anything there, then you go north.
Yeah, exactly. I mean, think about it. If you find any neurological symptoms, all right, it doesn't really matter what it is. The first thing you do is do a neurological exam.
Yeah.
You know, and make sure those symptoms are neurological. So it's not always about generating a diagnostic hypothesis. The hypothesis can be this is coming from the hip, this is coming from the neck, this is coming from the elbow, this is neurological, this is non-neurological. So your hypothesis isn't always a specific diagnosis, and you've got to work your way to that. Okay. So let's have a look at it. I've got it actually on a PowerPoint thing here. So I've fleshed it out a bit as well. So who is that here? There you go. Let's see if I make it a bit bigger. Try a slideshow, see how that works out. Okay, so this was a symptom, which is paresthesia in that distribution. Okay, so it's moderate. The onset was insidious over about a 4-year period. It's not getting worse now. The onset is mostly at night. It's inconsistent, but it occurs most nights, and it wakes the patient. If he worked for a period of time on the computer, he can also get it then. No past history of type, no medical history of significance, no lab studies done. The diagnosis from the referring MD was radiculopathy. All right, so I'll flesh it out because I want to give this to the other group as well. You good with that?
Yeah.
Okay. So this is my question then. what approach are you going to make, and what's your hypothesis? So again, the hypothesis doesn't have to be diagnostic. So I'm going to go through what I would do, and then we can discuss what you would do afterwards, right? Just to keep it nice and clear. So you've got a number of approaches to making this diagnosis. Pattern recognition, which isn't there really. I mean, this is not something you see every day, so there's no good reason for you to expect it to be able to recognize it. And I think that's a lesson that's worth learning, because you get to the point where you're making pattern recognitions all the time, and you feel the need, you feel you should make a pattern recognition on every case, but you can only make pattern recognitions on stuff you're familiar with. It's in the name. So pattern recognition is out. Hypothetic inference, script focus inference, positive differential diagnosis, negative differential diagnosis. So I think they're the approaches that are usable. Have you got anything else that you can think of other than those things?
No.
It seems to hit them all.
Pretty much encapsulates them. So your problem is you're unfamiliar with it, as I said. So pattern recognition's gone. The other big problem is bias. Because this is unusual, your biases are going to come in strongly. And the big ones are going to be availability bias, confirmation bias, anchoring, and framing. Now, it's unlikely you're going to get caught up in framing, because the doctor's diagnosis was complete and utter crap. I mean, for that to be a diagnosis is ridiculous as your primary diagnosis. So there are your problems. It's going to be a strong urge towards bias, and you can't do pattern recognition. And I think if you recognize you can't do pattern recognition, you're going to get rid of a whole bunch of trouble. Okay. So if we're looking at positive differential diagnosis, we can use hypothetic inference or script focused hypothetic inference. So the ones that I would think of here would be, the first one would be ulnar nerve entrapment of the wrist. There's no symptoms above the wrist. Although the symptoms are the same in the hand anyway, for if it the ulnar nerve entrapment at the elbow or in the neck. But the symptoms are going to be the same, but they're confined to the hand, basically. So it's unlikely to be above the wrist. On the other hand, weird stuff happens. So my next probable, it's not very probable, the next probable was an ulnar nerve entrapment. And then after that is a C8T1 radiculopathy. You okay with that?
Mm-hmm.
So if we look at negative differentials, though, these are more useful. Because we can use highly sensitive tests, or what we think are highly sensitive tests, to eliminate and get left with what we got. So if we look at those same three things, we should be able to eliminate this. And I don't know if I wrote the test there. I did, actually. So we've got the same three differentials, but now we're going to try and eliminate them, which is actually more scientific than trying to prove them. So as far as ulnar nerve entrapment is concerned, there's a couple of different things we can do. We can do Tinel's, although that's not specific for the wrist. If the nerve is caught up at the wrist and caught somewhere else, then Tinel's is likely to be positive. We can use wrist quadrants if you're looking for reproduction of symptoms, and we can do a maintained pressure on the nerve via the pisiform. So as it winds around the pisiform, we can push it there and hold it. Now, the reason for maintaining pressure is because this thing comes on after time. So it's a postural issue. So you shouldn't expect a positive Tinel's, really. If you hit it really hard, you might get it, but you really shouldn't expect a positive Tinel's because it's not sustained. Similarly, with wrist quadrants, we're looking for reproduction of symptoms. That's not going to help you out much at all. But a maintained pisiform pressure may do. If we can hold it there for a period, probably no more than a minute or so, because it's a lot of pressure at once, then we may actually reproduce those symptoms. Okay, but it has to be maintained. So these simple single maneuvers are not really going to work very well. Give me a minute. You didn't want to eat medicine. No, that's in the fridge. Sorry, guys. At the elbow, maintained ulnar abduction. So if this is caused by an abducted ulna or an unstable ulnar in the valgus, we can put it over there, put more pressure on it, hold it, and see if that does it. Is that okay? And the other one again is ulnar quadrants. But again, you're not doing it for very long. You're not holding these positions, so they're probably not going to be very useful to you as far as reproduction symptoms are concerned. The 3, C8, T1 radiculopathy, maintain stenosis position. So we put them into that position, hold them and see what happens. And then cervical quadrants. Is that okay?
Mhm.
So we still haven't made the diagnosis. I'm pretty sure this is going to end up being an ulnar entrapment neuropathy at the wrist, simply because of the symptoms are there for that. So in this case, though, everything's negative. I couldn't reproduce these symptoms with any of these tests. The question now is, what now? And this is where we got stuck, wasn't it, Anthony?
Nope, that would be me.
Yeah.
Where I got stuck.
Yeah. So, Anthony,
Yeah.
stuck you on there.
Yeah. I mean, I would have expected at least one of those to reproduce the symptoms.
Yeah.
Yeah. Um, is the paresthesia like, can you pick up on it during examination, or
Okay,
is that
as I said, ideally what we should have done was right at the beginning. We're going to say that there is sensation. No, there is no sensation loss. There is no weakness.
no weakness, no sensory loss? So he just has the pins and needles then?
Yeah.
Oh.
So the question is, and is this for you as well, why are you not picking up any neurological signs or symptoms?
Could it be vascular?
Okay, like what?
Yeah, I guess you still would. If you're still stressing the wrist, though, you would still expect that to reproduce some of the symptoms, like a claudication of some type. But you should.
Okay, so remember what I said before. Why are we doing the sustained pressures? Because he doesn't have any problems with his wrist at the moment. He doesn't have any problems with the nerve at the moment. He's asymptomatic at the moment. He gets symptomatic of working on a computer for prolonged periods and at night. So this is an on again, off again pressure. So it's unlikely, given that the nerve gets a chance to recover, it's not that intense, it's unlikely you're going to see any sensory changes or motor changes. If you made him parasthetic with your testing, then you might pick it up while he's still got paresthesia. But in the absence of paresthesia, you may well not find any sensory loss. Because this is what you have to remember, the pressure's on and off, and it takes a long time for it to come on. So you can't expect an acute presentation in the form of neurological symptoms or signs. So you have to remember the background all the time. The context here is it's postural. So it's very likely why your tests are not working, your sustained tests are not working, is you can't apply pressure enough for long enough. Okay, so hello, what happened there? So what I suggested was this is a multi-crush syndrome. And the technique for a multi-crush syndrome is upper limb tension testing, in this case with an ulnar bias. because you can sustain that, you can maintain it, and it puts maximum stress through the whole system. So I asked Jason why he never thought of this. I'm going to ask you the same question. Why didn't you think of it?
Yeah, it seems simple. I should have.
But why
No, I
did
think
you?
I just got caught up with just the negative, the negative Tonels, the negative
But you have to let all that shit go. You can't worry about why things are not working. You have to wonder what you can do next to make it work.
right.
If you get caught up on all that, you're not going to get any further ahead.
Yeah.
But the other reason that Jason had is that he doesn't use the test very often. The upper intention test.
Yeah.
Are you the same?
I would agree with that.
Yeah. It's in your toolkit. The fact that it doesn't get pulled out of the toolkit doesn't make it any less of a useful tool. You use it when you need to use it. But I call this unavailability bias, didn't I, Jason?
Yep.
I like that, actually. I'm going to write a paper on that. So. But it really is. You've got it available to you, but you don't use it. You're just not thinking about using it. So in this case, if you do the upper limb tension test, okay, and it doesn't really matter. If it's positive, then it would tend to prove a multi-craft syndrome. But if it's negative, you can't get rid of the idea that this is a multi-craft syndrome. Right? You can't prove a negative type of thing. So what I would do at that point is, because you really don't have anywhere else to go, is to do a biomechanical examination of the whole upper quadrant and see if any of what you're finding there matches the patient's problem. This is the taste it and see approach. But I don't think you haven't got much else.
Battery's dying.
Yeah, I think I should have used, I see it now as I was kind of reflecting on it, but I mean, like, if I can do anything that reproduces the symptoms or not, then you go hunting and pecking through the whole upper quadrant.
Yeah.
I think I just jumped here too.
Yeah, it's not likely to be at one point, because you've been doing these tests. You've done the quadrants looking at reproduction of symptoms. You've done the pressures and sustained pressures on each part. Now, if this was a single locus of the problem, the chances are you're going to reproduce symptoms. But if it is a number of pressure points over a few sites, then you may well not. Either way, you're going to end up doing a proper examination, a full examination of this. Now, if at the end of this, you can't find anything, that's your diagnosis. I have no idea what the hell this is. And that's a perfectly reasonable statement. Even for an expert, that's a perfectly reasonable statement at this point. But I think probably the key points here to understand is, have you ever seen this presentation before?
Not in the hand. I mean, I've had a couple of those patients with the numbness in the outer side of the foot.
We talked about that as well, didn't we? We did a case on that. What was your diagnosis with the pins and needles on the side of the foot?
When I'm trying to think, I haven't seen the guy in a while. He kind of fell off the map. I went with lumbar radiculopathy.
Yeah, see, that's back to availability. That's regression to the familiar.
Right.
Yeah, and you're going back to what you're familiar with. Whereas, given, I'm assuming there was no other symptoms through the quadrant.
He did have back pain.
Okay, so what you do now is exactly the same thing as we talked about. Your hypothesis is it's coming from the back or it's coming from the foot.
Right.
Yeah. Or it's coming from the tib fib joint, come to that.
Yep.
But your first job then is first off to do the neurological exam to find if there's sensory loss or motor loss anywhere. Your second job then is to determine where the site is. if you can. So if you've got a particular lumbar spine, actually your question now is, tell me about your back, tell me about your foot. If the foot's only just starting, the back's never been a problem, they've got no pain down the leg, as your pain got worse, which is why you would have referred pain in the foot or referred symptoms in the foot. If that's not got worse or they're not gelling with each other, then it doesn't stand up. But that's a process you have to go through instead of going to the lumbar spine and trying to prove the lumbar spine is the cause of the foot symptoms.
Right.
Because you end up with confirmation bias then. That's exactly what happens. You start off with availability bias, and then you support that bias with confirming that it is that by you proving it is that.
So when you have neurological symptoms like that, for example, I guess a good rule of thumb would be start from where the most likely cause is and work down. And if you don't find anything, work your way back up.
No, it's a bit long-winded.
Okay.
No, I would look, given that, I'm pretty damn sure, like if I've got neurological symptoms in the foot, I've got no neurological symptoms anywhere else, I'm pretty sure that the problem is local.
Yep.
I don't see it in the lumbar spine. I mean, the lumbar spine just doesn't do that, or almost never ever does that, especially paresthesia. Sometimes you get a bit of pain distal from where the site is, but paresthesia, which, like, what nerve is this?
Yeah.
You know, is it S1? Well, why are they not getting paresthesia through the rest of the leg?
Right.
So it's not a matter of going one end or the other. You can say, okay, which is the most probable? And I think this is probably important to overcome the idea of bias. Or you do it randomly. The best way of getting rid of bias is just to randomly and see what happens. But it's a very long-winded way of doing it. You're either going to start in the foot or you're going to start in the back. Not a lot of point starting in the middle. You start in the foot, you start in the back, and you see what comes out. I would go to the symptomatic area personally. But it makes more sense that the problem is in the foot than it is in the lumbar spine.
Right.
Simply because which nerve is this? What segment is this? You know, it isn't a segmental issue. If it is, it's extremely weird. It's a major outlier, and you're probably not going to make the diagnosis anyway. So I don't think it's a matter of picking one or the other. I think it's a matter of your brain should be going to what's most probable here. That's usually what it ends up being. Or you can do negative differential diagnosis and find the site that way, which is probably the least trend towards bias if you do that. Disprove each one.
I feel like the dermatome maps that we use too, or that we have used, don't help because they always emphasize the distal part of the segment. You know, it really doesn't.
I don't think it does. I think what may be doing that is your teacher. The distal part of the segment is the more specific area for the segment, but you have to go back to your own experience. When was the last time you saw a segmental problem that only had symptoms in the distal part of the segment?
Mm-hmm.
It doesn't happen. So it's more specific for that segment, but it's not sensitive for the segment at all. So you'd expect to see, if this is a segmental problem, symptoms pretty much throughout that segment. Especially if you're looking at dural or neural stuff.
Mm-hmm.
If you're just looking for a referral, then that's not going to be segmental anyway. That's quasi-segmental. But if this is paresthesia, then that should be specifically segmental, given the variations of the segments between individuals. Mm-hmm. But to see neurological symptoms only distal, it doesn't happen.
Mm-hmm.
Yeah. So you've got two approaches there. I think the least biased one is negative differentials. Mm. But you have to understand that most of the time we have no idea how sensitive our tests are anyway. I don't know, how sensitive is a quadrant test? How sensitive is palpation tenderness for a tendinopathy? I think they're both of them are probably close to 100%. The quadrants for joint problems and the palpation for I think they're close to 100%, but I don't know that.
Mhm.
So at the end of the day, if everything's testing out negative, I've then got to question the sensitivity of the tests I'm using. This is a researcher's issue. They're not doing the right research. If they were, we'd have numbers on this. We'd have more confidence in the tests we're using, or we'd have less confidence, because the tendency is not to undervalue the test, it's to overvalue the test. Oh, I did quadrant tests on that. It was negative. It can't be that. That's not the right statement. I did quadrant tests on that. They were negative, so it's almost certainly not that. That's a lot different from it can't be that. And this is attitude. If your attitude is probabilistic, then you're going to do a lot better with difficult cases. Now, the point I made with Andy is, what I'm giving you are cases that probably won't show up in your clinic every 10 years. And I wouldn't do this if this was certification. But because they're not turned up in your clinic every 10 years, they're going to turn up in 10 other people's clinics every year for you. So if you're getting referrals from other therapists, you're getting referrals from 10 therapists, then you're going to see one of these a year. Not once every 10 years, or once every month instead of once every 10 months. But if you're doing consults, then you're going to see these much more frequently than individual therapists who's sending you consults. Plus the fact, you're an expert. You should be able to put, it's not a matter of pattern recognition here. It isn't pattern recognition. This is not how many of these you've seen, it's how you work your way through a problem. It's your process. And process is not static. It's not a structural thing, but it's how your mind works. You don't have to use the same process every time something happens, but your process has to be logical. I think of all the things we have to do in clinical reasoning, it's not research evidence. All the other shit they come up with is logic. You have to be logical and rational in the way you go about things, and not jump about. Your biases, but you have to eliminate those as you go. But you can't afford to let them mount up. So have you got any thoughts on this? We did do this. I know we did this with the foot, didn't we?
Yep.
Mm-hmm.
Yeah,
No,
I still haven't gotten anything back on his neuro. But
sorry, say again.
that guy that I was telling you about with the foot stuff, I haven't gotten anything back from his neuro.
Yeah. There's stuff you can't work through. I mean, it's just too bloody, there's too many things going on. The patient's too vague. Your signs and symptoms are too vague, which would ordinarily not be a problem, but when you now match that with the vagueness of the patient's history, you're going to get fucked every time. You know?
Yeah.
And multiple complaints, or not multiple complaints, but multiple pathologies for you up every time. One of my biggest problems is trying to sort out what's happening in somebody with a spondylolisthesis and a badly degenerated disc herniation. I mean, you've got two things going on there. It's going to look like a disc and it's going to look like a spondylolisthesis.
Yeah.
And if your objective testing's not working, then you're screwed. And even if your objective test is working, if it's not reproducing the patient's symptoms, is it relevant?
Right.
Yeah.
Mm-hmm.
I think the thing that throws me off the most with people is just when they come in and they have the multiple complaints. Am I seeing, what are you really complaining about? And then what else is just kind of there to really establish, okay, what am I looking at as a diagnosis? And
did you ask that,
could
didn't
be-
you? Don't you ask that? Which of these things do you want me to tackle most?
Yeah.
Yeah.
Well, I'll have patients that have back pain, and I have patients that also tell me they have like ankle discomfort, and running and stuff like that. That's the two big things.
Yeah, but that's what I would say. Which of these two things you want me to tackle first? Because if you try and tackle both of them at the same time, it ain't going to work for you. It's not a matter of not treating both, but if you ask me to try and work my way through the problem of both at the same time, it's not going to happen.
Right.
Yeah. So
what
do you want me to look at
establish?
first?
Well, I mean, especially if you're talking about the same quadrant, like if it's right-sided low back pain along with like right ankle discomfort.
Ah, you're making
Like,
assumptions. Now you're making
right,
assumptions that it's the same thing.
right. Yeah, that's what I don't want to do. So
Yeah.
it's like, how do I establish if one diagnosis is playing off the other, or do I say one is the etiology? I mean, I guess going through now sorting out the long leg, short leg thing, it's quite possible that the ankle was the driver and the
But
back
you
pain is
don't,
the diagnosis.
why do that? Look, this is Occam's razor, and Occam's razor generally is a good thing, but not always.
Right.
With you've got Occam's razor, which says you should multiply pluralities more than you need to. That it don't make it too complicated. Clinically, it's most likely that the patient's problems are coming from the same source. This is medicine, mostly medicine, but it's likely that all of their problems are coming from the same source. Occam's razor. There was another one, I can't remember the guy's name, who said the patient can have as many damn problems as he wants to. So Occam's razor works best in the abstract. But when you've got a variable machines like the human body, it may or may not work. So assuming that it does work is not going to help. So if I've got these two things going on, first off, most of the stuff, like when we look at etiology, most of your etiologies are hidden. They don't, the patient doesn't know about it. They come in with their main complaint, and that's it. So if I'm looking at, all right, let's say this, I've got a patient who's got discomfort in the ankle and he's got back pain. And which one's the worst? So let's say the ankle's worse. This is what I want sorted out first. So you do an examination of the ankle and you say, okay, yeah, you've got subluxated crural joint. Okay, now you're back. And you go up there and you find an extension subluxation at L5S1 on the right. So you say, okay, these two are very probably interconnected. Okay, but you've looked at them both separately and now you're putting them together. You know they should have a long leg from the sublux ankle. Now, the question is, how does the back pain or the back problem cause a subluxed ankle?
Right.
So if we're looking at etiology and we're looking at cause, it's almost certainly that the ankle is the cause of the back pain. Now, the question to the patient is, did you injure your ankle? Now, if they've got no history of injury of the ankle, then you're going, okay, now what's caused that? So if we start thinking about why they would have that, well, the obvious one is they've got an unstable inferior tib fib joint. Yeah. So why would that spread? Okay, well, maybe they've got weakness of the gastrocnemius. So your sets of gastrocnemius and it's weak. Now, the question is now, is that weakness in the gastrocnemius due to reflex inhibition from the ankle? So it's an effect of a subluxation, or is this more segmental? So part of maybe segmental facilitation. Let's look for weakness at hamstrings. Now, if you find weakness at the hamstrings, then you can start saying, okay, it's likely to be segmental facilitation. Let's wobble back to see what happens to the strength. If you don't find it at the hamstrings, then, and they've got no history of an injury to the ankle, you're still left with the gastrocnemius as being a possible cause of the ankle. Wobble the ankle. If that now goes away, it's reflex inhibition, probably because the ankle subluxed, and you may never find why the ankle subluxed in the first place. But you see the process, it's much more flexible than, okay, they're interconnected, it's got to be coming from the back. Let's trace it there. It's that initial process, I believe it's the initial process that makes you more flexible in the way you think. Not assume anything, not assume Occam's razor is happening, not assume it's all coming from the back. I mean, and also don't forget, when I find evidence of segmental facilitation, that could be coming from the ankle as well, and not from the lumbar spine. But of course, in this case, it doesn't really matter because you're going to end up treating both anyway. You don't have to get your knickers in a twist about it.
Yeah.
It's probably an obvious question. I'm working my way through what you said about the gastroc. Why would the weak gastroc cause the sublux?
Because you over dorsiflex the ankle. But part of the function of the gastrocs is to control dorsiflexion of the ankle. Yeah, through its tone and through contraction. So it stops the ankle over dorsiflex, and then it allows then the fluids to pick up the talus and drive the talus down, and then close pack the foot.
Okay, I got it.
Close pack it. So if the gastrocs is weak, you over dorsiflex the ankle and not flatten the foot.
Yeah.
And then you sublux the ankle. Yeah.
Yep,
Yeah.
I get that.
But this is the biggest problem, I think. It's almost breaking conditioning. It's not making assumptions, even simple ones. Like it's ordinary cases, you can make assumptions. You can say, okay, then I'm pretty damn sure it's a biomechanical dysfunction. It's not looking at etiology. I'm damn sure that's a biomechanical dysfunction. Let's use the illness script, or let's use what I know about this and prove it. Okay, now leaves you open to bias, but the chances are you're going to be right. This is pure pattern recognition. So you make the decision almost immediately. You do a couple of tests to confirm it. Not, should we go? It's script focused hypothetic inference, automatically done. And if you're doing pattern recognition correctly, you've already compared it, usually unconsciously, with 2 or 3 differentials. That's pattern recognition. It's almost always accurate. If the clinician keeps on self-doubting, self-criticizing, and constantly reflecting on the practice, that will work very well. It's when the clinician gets to be so bloody good at what he does, I'm the best thing since sliced butter, I don't have to do this anymore. That's when they get arrogant, and then they get sloppy, and then they make mistakes, and they go back to what it was before they were good. And you see this all the time in surgeons in particular. So it's not making assumptions, particularly on cases that are unfamiliar. You've got to treat an unfamiliar case like an unfamiliar case. It's no good fitting it. It's no good assuming that this is really something very unusual and then giving it a usual diagnosis. It makes no sense to do that. Yeah. Yeah. Anything else on that?
Nope.
Yeah. Okay, well, that was exhausting. I'm going to give you a job to do. We're meeting tomorrow, aren't we?
Friday.
Friday? I've
Friday,
got
10 a.m.
22nd, 25th, 29th. Yeah, okay. So I'm going to give you a job. What I want you to do is teach me. Andy, talk to me on Friday about neurological etiologies. All right, and what I'm talking about here is not frank neurological conditions. Actually, you can. So talk about neurological etiologies and why frank neurological conditions like radiculopathies do not cause etiologies. Right. The other neurological etiology is obviously oh God, what's it called? Axoplasmic flow problems.
So you want me to say it one more time? Neuroideologies and why Frank? What was that?
Neurological conditions don't cause problems in athletes, right?
Okay.
And then I want you to talk to me about the etiologies caused by axoplasmic flow dysfunction.
Okay.
Right. 10 minutes. Jason,
Sir.
you can talk to me about multi-crush syndromes and how they cause problems, all the various ways they can cause problems.
Multi-crush syndromes and how they cause problems.
Yeah, their etiologies. Actually, and what causes them. Okay, talk to me all about axoplasmic flow. Yeah, multi-crush syndrome.
Okay, multi-crush systems, how they cause problems and their etiologies.
Yeah, all about them. Tell me to me all about them. There you go. All right, so we'll spend the first 10 minutes talking about those. And it'll probably spread out.
Got it.
Okay.
Yep.
I didn't know this. I was looking, I was watching YouTube, and there's a thing called the Feynman method of study. And this isn't new by any means, but I've never heard it called that. It was named after what's his name? Feynman. I can't remember his first name. Richard Feynman, the physicist. And it's an old idea, and it works. If I don't do it, I can't learn anything, and that's to teach it. The best way you can learn anything is to teach it. So we'll do a little bit more of this, all right? I'm not holding you to that December 8th date or whatever it was.
Okay.
For the exam, so we can stretch that a bit, but let's do a bit more of this. You can start teaching me some stuff.
Okay.
All right.
All right. Yeah, Anthony and I
Okay.
will kind of talk and we'll see what we can kind of figure out. I mean, I think, at least for me, I mean, if we started online and see how that goes, I feel a lot better than where I was, you know, probably about a year ago with some of this stuff.
I would bloody
Or at
hope
least-
so.
Yeah. Yeah.
It's flexible. You can do what you want with it. Like,
Okay.
But if we do this, if once it's done, it's your 1250 gone, basically.
Okay.
You know.
Okay. Got it. Okay.
There's no rush. Okay, guys. I will
All
talk
right.
to
Sounds
you
good.
on Friday.
All right. Sounds good.
See you
All
guys.
right, thank you.
Bye.
Bye.